I think this, I shall start straight away with this case. We started to discuss a group of cases starting from case number 8 and then moving now to case number 9. And this case number 9, the history which I have given in this was 24-year-old female patients presented with pigmented lesion on the chest. Doesn't matter if you've seen the case before or not, but some of you, I understand that they might have accessed the case before. It is again continuations of our melanocytic lesion discussion. And of course, once the age is young, you should be very careful if you are going to label any patients of yours in the exam as a melanoma, but it doesn't stop you. And the problem is the problematic age that we tend to get in the exam is the 24, 34. Obviously, if I am to give you a patient who's 60-year-old with a lot of junctional activity, you are more likely to consider this as a melanoma even before you put the slides on the stage or dysplastic nevus. But in the exam, they tend to, for melanocytic lesion, to give you that age 24, 34, which is an age that we tend to see melanoma developing in the Western world. So it doesn't mean that 24 or 30-year-old is a young patient for developing melanoma. No, these patients can still develop melanoma. And then the other problem is that what would be the cutoff then for you in your mind between what can appear sometimes in children and when you will have to change that name a little bit to suit the age, which is another problem that you might be facing in the exam, especially if your teaching was a little bit traditional. But this is quite large lesion, okay? And in general, there is a general rule in most of the melanoma books that they will tell you majority of the benign nevi are 10 millimeter in diameter or less, okay? So that's including the intradermal nevi, the compound melanocytic nevus, you know, all of those sort of things. So generally, so if the lesion is quite large in size, this is the first things that should drag your attentions to the details here. But then the second thing is you need to assess the symmetry of the lesion. And from the last session, I told you the symmetry means that if you start with a large nest, you end with a large nest. If you start with a small nest, you end with a small nest. If you start with only lentiginous proliferation of melanocyte at the junctional component, then that should be also the same ending on the other side. And here you are able to see that there is a nest of moderate size, and there's another nest here on the other side. So to some extent, to me, this will be kind of symmetrical, okay? But symmetry alone doesn't work enough. It's not enough to tell me that this lesion is benign or malignant, but it is just a way of assessing things, okay? So do not just get too excited and from symmetry alone, you decide, because the reason behind this, because if you have a pre-existing nevus and you start to get a malignant transformation into this nevus, then it usually happens toward the center of the lesion, the problem, okay? So you might have your benign nevus with a symmetrical architecture, but your problems is happening more toward the center of your lesion. So this is one thing to keep in mind, because there are some melanomas, especially the superficial spreading subtype, can arise in a background of a compound nevus. And therefore, this will be important into the context. For this particular lesion, I did put it because of what will come next. But you, in order to understand the next case, which is case number 10, you need to understand how you will deal with this group of lesions when you get struck with it in the exam, because then it will make some difference. So the striking features here, which is that the nests are in the papillary dermis, okay? Although there are some nests in between, but the predominant pattern of where the nests are is basically here in the, it is only here in the papillary derms. So you can see there are nests which are filling the papillary derms, although the cells looks a little bit large, and you can see the nest in the dermis appears slightly irregular. And but these are all the important things that you need to pick up at a very early stage. Where are the nests? Okay, and this is one, believe me, when I see sometimes, and I'm sure some of you are 10 or 15 years experience or even more. And what I tend to see that I see a lot of people look at these nests, they look horrible. Yes, absolutely. And they have some variation in terms of shape. As you can see, this looks a little bit irregular. This is large, this is small, and they are distributed throughout. So this is important because in some types of nevi, this feature, which is the irregularity of the nests, this will come under the heading of what we will call it architectural atypia, or architectural complexity of a lesion that will make this lesion dysplastic or malignant. So this is the number one confusing point for these particular lesions. Number one confusing point, that the nests tend to be irregular in shape, irregular in size, but the predominant pattern of the larger nests, as you can see, they are filling the papillary dermis. And this is important. The second thing, which is an important features, and we will be building on the features now, and believe me, it will all make sense when we finalize the entire pictures by the end of the lectures, hopefully. But the second important thing is that retraction artifacts, of course, which is quite obvious for everyone was looking into this lesion here. But you have to be careful with the retraction artifact, because one thing that you will also be able to see in some of melanocytic, in the melanoma categories, that you might find, you might find, I'm so sorry, just let me just delete these annotations somehow. Here we are. Okay, so what I mean is that you might find retraction artifact in melanomas, but how the cells behave after the retraction artifact is very important, because you need to decide if the cells now has become, it's detached from the corners of this nest to become discohesive in the middle, or do you still find the cells trying to stay together? They are trying to stay cohesive. So this is important, because when you can see here, these are staying cohesive in the middle, but in melanoma, although you might see retraction artifact in some of the nests, but you tend to see the cells when they fall into the middle of this nest, will become very discohesive. And this is also another important feature. And then you can see these eosinophilic bodies here and in top of this nest. Let me just annotate this as well for you guys. So over there, so this is the cheminobodies basically, which are quite identifiable in this type of lesion. But there are, you see, one of the things in the FRCPath exam, that when you see a certain diagnosis, you move to the next one, you know, like you move to see if you can upgrade that diagnosis to something else. So for example, if you have a cervical biopsy or a LETS specimen in the exam, and you did find the CIN3, don't stop there, okay? Because there might be very florid CIN3 with a very tiny focus of 1 or 2 cells of invasive carcinoma. And obviously, if you miss it, it's not the end of the world for the patients, but it's the end of the world for you in the exam, because that means that you missed the invasive malignancy and you only call the pre-malignant, the CIN3. But then also, even if you see the CIN3 and you saw the malignancy, just move on to the glandular component, because you are most likely going to find also a high-grade C-gen in the specimen. So why I'm saying this? Because this does apply to our melanoma scenario here. One thing about this lesion that I would like you also to be able to, to identify that, yes, there is a dermal component, and we will come to that in a minute to assess. But these lesions also tends to have a quite confluent hyperkeratosis on the surface, which is not a feature that you tend to see with a lot of melanocytic lesion. But this hyperkeratosis, it's not normal things, because it is just a finding that we tend to find here, and it's good. You can see when I go out of the lesion, there is hardly any here. Can you see that? So no hyperkeratosis there. But when you go toward the center of the lesion, the hyperkeratosis is getting thicker and more prominent, which also define these lesions as a crown for it. But these lesions tend toward the middle of the field to show some unusual features. And obviously, I think majority of you now would be able to consider diagnosis of a Spitz or Spitzoid lesion. And now the next question will be, are we going to upgrade this? Are we going to call it a typical Spitz, especially with the age, okay? Because we have to be careful here that this patient has got an age of 24, and this is the cheminobody. It's just someone was asking to show it. It's just a eosinophilic aggregates. It's like a colloid bodies of some sort that tends to just aggregates here at the dermal epidermal junction. So just to show you that here again, okay? So sometimes you find it even more prominent in some lesion, but this is how it is. So in order to answer this question of the upgrading, the atypical Spitz is a term you might find it in a lot of books, but people tend to try to not to use it, and then they try to say, okay, Spitzoid melanoma. But obviously there is a difference between the atypical Spitz, where you cannot upgrade it to melanoma because you don't see enough features to upgrade it, and there is full-blown melanoma that start to invade and destroy the tissues and has got the potential to spread. But how can we reach this in reality? The thing is that people talk a lot about pagetoid spread in Spitz lesion, and this is one of the confusing part, because you tend to have cells are migrating up into the lesion, and if you are if you would consider that only pagetoid spread will be enough to upgrade this, for example, let's say melanoma in situ, or you always rely on pagetoid spread, then you will almost always call all your paget as a Spitz. You can see there are some cells here in the middle of the field now that are trying to go up, and they are even in aggregates, you know, like they are not single cells, they are trying to be 3 cells together in conjunction. Here again, on to the side now, I am just bringing it to the middle of the field. There is a little bit of a little nest trying to come upward. The majority of the authors in papers and books as well will tell you that most of the Spitz nevi will have pagetoid spread in them, but they tend to be confined to the lower half of the epidermis. So if you just do a line, then they tend to be confined to the lower half of the epidermis. The other things as well, that if they are to go into the top half or into the granular cell layer, then you will consider, okay, there is a problem here, but I wouldn't rely a lot on it if it is in the center of the lesion, okay? So, and that will mean that you need to see exactly where do you see the pagetoid spread. Is it toward the center of the lesion, or it is spread throughout, and if you go very, very lateral, you can start seeing some pagetoid spread. So this is a very important features to understand how on earth this pagetoid spread will work, because you might then see only pagetoid spread, which is quite confluent, but it is in the center of the lesion alone, and then I wouldn't use it as a sole criteria to upgrade this to atypical or to a spitzoid melanoma. The second part of the assessment will include looking into the shape of these, the directions of the cells in the nest. And people describe it normally as a rainfall. And what do they mean? That it has got somehow majority of the cells. And you have to be a little bit pragmatic here when you look into those, because not every single cells will have this vertical alignment, okay? But generally speaking, if you look into the cells, the melanocytes, you will be able clearly to see that there is a vertical alignment of the cells inside the nest, and we call it like a rainy local rainfalls, which is basically telling you as well that this nest did not change directions. Although when you have a nest entrapped in the middle, it is difficult sometimes to know what it is. This might be just a fusion between the nest. The fusion can happen in Spitz, and I personally, again, don't get very excited about it. But one of the, I am still in the junctional component, and you see, because it's very important to stay with it. If the cells themselves in form of atypia, they are not going to help you a lot. And in Spitz, you might get mitotic activity, you will get large cells like the ones that I am putting in the middle of the field now. These are very large cells, prominent nucleoli. You apply your normal rules for atypia, you will find that it does work here. You see, even there is very, very prominent nucleoli, which we can see in one of these cells here, you see. So these are all features which are, if you rely on it to determine the atypia, then again, you will end in calling all of these lesions as atypical, and you will be wrong. So atypia is not going to function in SPETs in the junctional component because the cells are big, they have a prominent nucleoli, and it is, well, it is as good as it gets for atypia. You will see it there. But one important aspect that people tend to forget, and we will go to low power to try to appreciate that a little bit. You see, in these, the people, the clever people will tend to try to lump a group of melanocytic lesions under the spindle cell heading, yes, because the cells looks epithelioid to spindle. That's fine. If you are one of those, that's fine, providing that you know just the subtle differences between the subtype that has been lumped into this. But they are all variants out of that group. That's absolutely fine. But one thing as well in the low power, I want you always to appreciate when you look into melanocytic lesions is the fact that you are still getting in these lesions elongated, very long rete ridges. And these elongated rete ridges that you can see it across the board here, these are not particularly a feature that we tend to see it in melanoma in that form of uniformity. You see, majority of the rete ridges, if I am to go here with a horizontal, with a pencil, just draw at the base of this rete from one side to the other side, you will find out that these rete are long, but a little bit uniform in terms of length. The uniformity we means by it is mainly for the format of lens of this rete. And this is not really a feature that you normally see in melanoma. In actual fact, you can see a lot of epidermal consumption in melanoma, or irregular or shortened rete, and as if the nest's trying to replace them in a way. That's another important aspect of how you judge on the junctional component. But again, if usually the melanocytic lesion, the malignant one in particular, will show most of the malignant features toward the center of the lesion. And this is exactly what I'm going to do now, is to just go directly to the center of the lesion here. And there is a very important phenomena that I wanted to show you. And I really wanted you to focus a little bit on. In melanoma, especially in the center of the lesion, when most of the problems happening, the melanocytes in between, the epidermis in between the nests will start to have what you can describe it as lentiginous proliferations of melanocytes. But here, in this case, you can see that these are keratinocytes, and these are the melanoma cells, the melanocytes here, which are the one that is going upward. I want to also to highlight for you an important features. If you have a normal melanocytes, and next time you look into a skin sample, just go a little bit into this and have a look. Or an inflammatory skin of some sort. What you will find that the melanocytes tend to stay a little bit higher up than the basement membrane. And when the melanocytes become in the malignant era or in the atypical era, they tend to go down a little bit, so they don't lie above the basement membrane, they lie at the basement membrane or just slightly hanging below it. So this is just a feature that you can be helpful You know, when you see a melanocyte that's lying above the basement membrane here and not trying to indent into it or go below it, this is also a feature which you can use. But that's not the point here. The point is that in between the melanocytes, we have normal keratinocytes with no melanocytic proliferations at all. And this doesn't happen in melanoma. But all of these features, which I'm saying, will help you to determine on this. I told you mitosis can be present, especially if it is irritated, like scratched or traumatized by claws or something. But yes, if you have a frequent mitotic activity, then you will be worried, but I wouldn't be, again, relying on it as a persuading factors to go for it. Okay, I told you they can fuse. So for those who relies on the fusion and the architectural bridging of melanocytes, they will be disappointed. The other features which I also wanted to stress on today, because I find that people, again, quite misled by it. I will go to the corner of this lesion to show you that feature. Now, a lot of people has got the concept of that the architectural atypia, or one of the architectural atypia features in melanocytic lesion is shouldering. Okay, I guess we all agree that shouldering is mentioned everywhere. And what it means in simple terms, as you all know, that the junctional component extends beyond your dermal component. Okay? But in actual fact, this is not a problem that I would or a rule that I will apply for all your melanocytic lesions, because sometimes depends. Sometimes you have a minor dermal component in a compound nevus that's predominantly junctional. So how can you judge that then? And the other things as well is that if you start have early melanoma in a compound nevus, I just told you a few minutes back that you will have a kind of like changes in the center, while the peripheral will look very normal. So if you don't have shouldering, then wouldn't you consider this melanoma? Then there is a lot of things. So it doesn't, either way, it's shouldering alone can be helpful. If the entire lesion is malignant, then you can use shouldering, yes. But don't forget that there are some examples, which like the examples which for those who listened to me last time, in lentigo maligna melanoma, when it turns into completely malignant, then you can start to have an early invasive component. So that will be a dermal component in a melanocytic lesion that has got a very wide shouldering then. So shouldering is okay. I wouldn't stick to this again as a feature. Also, I know in McKee, it has been mentioned a lot, and I'm not criticizing here, guys, but you just need to, don't apply it for all. There is no one that works for all, and this is what is important here. The other things as well, when we move on to the junctional component, one of the things that you will realize in here that if you are relying on the fact that you normally in melanocytic lesion and superficial spreading melanoma, especially those with a vertical growth phase, they will have the nest, which will be in the dermis, shouldn't be larger than the large nest which you have in the junctional component. Because if this is the case in melanoma case, this will be a vertical growth phase. But here you can see that you still can get a very good sense of the spitz cells, which are forming very large nests. ideally, the nest should get smaller. But if it doesn't get smaller, because the lesion is quite superficial, for example, then it doesn't stop you from, you shouldn't still calling this melanoma. Let's move on to the more difficult part. The more difficult part of the things is, okay, if you look into the cells in the nest, without comparing it to the junction, you will consider, again, every single cell standing in this field as atypical. And then you will end in calling this lesion as a melanoma. But this, again, will be wrong, because these cells exactly has got the same morphology as the cells here in the junction. Now, and this will lead us to another role, and this is important, that the lentigo maligna, which are a little bit small nevoid to epithelioid cells with lacunae, when they tends to invade into the epidermis, will tends to acquire a shape like this, similar to this in a way, okay? But in the superficial spreading melanoma, which is predominantly spindle to epithelioid, in the junctional component, then this will tend to be a little bit more of, will acquire more of a spindly look when they start to invade, and they will become with very eosinophilic cytoplasm. And we will see that difference in a few minutes, because I think I have an example to show you. So if you go by the papers which has targeted the areas of atypical splits, then what are really the reliable things to decide in the epidermal component? Number one, you cannot rely on the atypia. So providing that you understand that concept, then you will be fine. Okay, so number one concept, that you cannot rely on the atypia at all. Number two is that if you draw a line below the dermal component here, you will find that it's nearly kind of ending at the same way. And majority of these lesions, people describe them as a wedge. And this is because they tend to have that tilt toward the middle, toward the center, and then they go shallower again toward the periphery. So they have this wedge shape into them, and that give it the appearance. And as soon as you see that wedging, you know that you're probably dealing with a normal. But when you're staying in the middle and the center of the lesion, you will see that they are ending approximately at the same line, which is the normal melanos, the malignant melanoma will not do that. They do not behave in that sense. This is one thing. Yes, in terms of maturation, yes, there are some maturation if you want to rely on maturation. And maturation in melanocytic lesion, people can use a lot of criteria, but the criteria which collectively, especially in the other type of lesion, not in spits, but in other type of lesion, that the cells tends to be lighter and larger higher, smaller and darker lower down, okay? But this is not the only maturation. There is something that we call it maturation of nests as well. And which means that the nest can be bigger, and as you go deeper, the nest will become smaller. So you don't need to see this phenomena universally all over the lesion, but once you saw it in some parts of it, you know there is an element of maturation. But what else? There is an important features in other lesions. I will show it to you, but here it won't be very specific here. But what it is that, you know, that rule of larger cells higher and smaller cells into the lower part, this will also apply inside the nest. So next time you are dealing with a compound melanocytic nevus, just go to the nest in the dermis and you will see that phenomena. The cells will be larger in the periphery and lighter with a lot of cytoplasm, and as you go to the center of the nest, they mature. And so this maturation within the individual nest, which is quite important. The other things which people relies on in maturation as well, when they start to see collagen dissecting more between the nests. So this phenomena is usually better to appreciate at a low power, because it's basically, you see that the nest will be more crowded with less collagen, and there are some individual cells here. And as you go down, you start to see the collagen becoming thicker, and you will see that it is more trisecting in between the cells. This collagen phenomena, you can see it here again into this part of the field. So you can see there is more densely populated things here. And once you see a lot of more collagen, this is, in my eye, is a maturation. In spits, you are allowed in the upper half of the lesion to have mitosis, but you are not allowed that in the lower half. So what it is that if I am to think that I am seeing mitosis in the lower half, or seeing marked cytological atypia in the lower half, or seeing the fact that the collagen is not there, this collagen which we talked about, and all of your fields start to look something like this, rather than this collagen that's segregating the individual melanocytes, then I would start to think about the spitzoid melanoma or atypical. Now, it depends on the age as well, because spits usually will fade and disappear by the age of 25, 30. But if you're still getting a lesion with the spits and you think it is atypical in a 40-year-old, then I probably will call this melanoma. Now, the differentiation between atypical spits, if you see some but not all, some people will call it atypical spits, but it has to be treated like melanoma. Or if people are seeing all the features or all the problems that we talked about with horizontal alignment up, a lot of mitotic activity scattered everywhere, a lot of atypia, lack of maturation completely, and sometimes it's digging more deep as well. If you're seeing all of those, then call it melanoma. The problem of atypical melanoma, when atypical spits, that you will find out that there are a lot of reported cases, which goes between the fact that atypical spits, a lot of cases presented with metastasis. So this is a danger, of course, so that if your clinician does understand that, then that's well and good. Now, there is an important part I wanted to talk about, and for those who like to write, please, I want you now to focus with me in what I'm going to say for the next 5 minutes, and these are important things to write. This will apply to any short surgical as well as the long surgical cases for the exam. We talked about the section 4 in your writing, which is the additional points and clinical pathological correlation. Okay, so how are you going to score that extra half? This is what will take your mark now from 3 to 3.5. Okay, so we are talking about that half mark, and which is quite important. The first one, I will always correlate my case to the clinical history that I have been given, okay? So in a case like this, for example, spits, if I am to write my clinical correlation, I would say these are common before age of 10. Clinically, they have got this distinct appearance with well-circumscribed nodular appearance. You see, you are describing the macroscopy of this lesion, and you are correlating it with the age, okay? although you will say, although it is unusual for these lesions to persist at a later age or late or early adulthood. However, there are cases which can still acquire these residual phenomena. So this is number one in that writing for clinical details. So you can tell me how it presents first macroscopically, and you can tell me to correlate it to the race, to the age, you can correlate it to the patient gender as well. So that's absolutely fine. The second thing is that you need to tell me if you know a certain protocols around this case. And what I mean by this, that if this is a malignant melanocytic lesion, then I would expect you now in point number 2 to tell me that this case will be reported as per the standard data set issued by the Royal College of Pathologists. And this data set does have a lot of prognostic and behavioral features. And for example, if you have this as a malignant, then you will tell me some of the relevant prognostic factors like breast thickness, for example, like the number of mitotic activity, if you saw any regression, the vertical growth phase or radial growth phase. So these things I expect you then to mention them to me here, because you can tell me some of these prognostic features, poor prognostic features, which I have identified as follows. For example, peritoneal invasion, lymphovascular invasion, whatever you find, okay? So these are important to highlight into this. The third point is to think that if this case does apply to a certain protocol, and what we mean by this, that if you consider, for example, a case of let's say a squamous cell carcinoma, that it is incompletely excised in the section which you're being given, then ideally what you should then be giving the advice of what for the clinician to do next. Okay, so this is another thing that you need sometimes to mention it in your report. So if you have a patient presented, for example, a famous case came 2 years ago, which was a case of lymphocytic gastritis. Okay, so this was only lymphocytes increasing, of course, in the lamina propria, but a lot of lymphocytes into the surface epithelium and in the crypt epithelium. And then ideally you should link these cases to Crohn's and inflammatory bowel or celiac or whatever correlations this case might have. And this will be important. The other things as well to think about is think of systemic relation of the case to other stuff. So if you, for example, you have a history of a chondroma in the lung, or then you can say, yes, Carney syndrome, for example. So what I mean that if you know there is a syndromic relationship to a certain case, then this is another point to add. So this is also a very important one. Now the fourth point is think of the prognostic factors that you might find in any lesions, other unrelated prognostic factors. And this is, for example, to tell me if you have for example, EBV positivity in some lesions can affect the prognosis. If you know that, for example, a famous case that does come into the exam a lot is the inflammatory bowel, the ulcerative colitis with CMV. So you should consider the CMV in the case as a fulminant colitis, because basically this means that these patients can produce to toxic megacolon and septicemia and severe illnesses within days. So these are all important things. Of course, these are things you can add. Another thing is think of added useful investigation. And what I mean by this is if you think that microbiology will help you, then by all means do it. So if you have a case of colitis and you don't know if it is infectious or not, then correlate it. If you have a case of a pseudomembranous colitis, correlate it to microbiology by all means. So the same for granulomatous inflammation, for example, just say, I would like to correlate my results also with the microbiology results, because that might be helpful. But don't only think of microbiology. In the same sense, you can think of serology. So you can ask for the, if you get a case of celiac disease, you can ask for serology. If you have a vasculitis case in a skin, for example, then you can say, I would like to see the serological markers like the ANCA and this, and the antiphospholipids and the other antibodies that's linked to vasculitis. So this is also a correlations. Blood tests, like just a simple things like eosinophilia, for example, which you can see in the background of some lesions. These are things which I will put. The other things, if you have a leukemic deposit, for example, in the skin, just go back by blood test, yes. Flow cytometry, if you have a lymphoma case that you cannot diagnose, or you don't have immunohistochemistry to diagnose, but you think it is, for example, non-Hodgkin lymphoma, say yes, you'll do your immunohistochemistry and everything as additional work. But then don't forget, you can also tell the clinician that I would rather correlate this with flow cytometry because this can give me an idea. Another point, which is number 6, think of the molecular link, okay? And what we mean by this is that if you have a soft tissue tumor of some sort, Ewing or something, that you can define a molecular test that will help you for example, liposac, MDM2 or CDK4. So you can definitely put this molecular link into this. But even for cases which you will suggest that you will do it, like a hot case now, it's not hot for diagnosis. It's easy to diagnose adenocarcinoma in the lung, but what people or the examiners now in the college, they tend to bring it in because they want to see a molecular knowledge into that case. Are you going to suggest that you will do the EGFR, ALK1, and the PD-L1 as part of your molecular testing? So if you're not familiar with those 3 markers, just please familiarize yourself. We do them in the United Kingdom routinely now on the non-surgically treated adenocarcinoma of the lung. So we do EGFR, and we do the ALK1, and we do the PD-L1. But in a melanoma case, of course, you will be suggesting that you will do the BRAF testing because this can guide the treatment of this case. So this is another point. Point number 7 is to think of if you need to refer and discuss this case in what we call a multidisciplinary meeting. And for those who are not familiar with the United Kingdom system, for every specialty, subspecialty in pathology. We have a specific meeting that we do it with the oncologist, with the surgeons, with the radiologists, with the radiotherapists, the dietitians, everybody, community nurses. Everybody is attending this meeting, and then we decide on what is the best action, best treatment to be done. But so you can say the case will be discussed in the MDT, but just to say why, just to say to discuss the options, for example, of wider excision, to discuss the options of doing a sentinel lymph node sampling with wider excision. In melanoma lesions, which we are talking about today, if you have a tumor that is in vertical growth phase, or it has got mitotic activity in the dermis, then this is an indication for or Breslow above 1, then these are indications to do a sentinel lymph node. So for example, if you know that, then by all means you should add this as a prognostic features. So another thing says that I get sometimes asked, do we need really to measure the Breslow and determine or the Clark's level, providing that diagnosis, for example, as a malignant melanoma? Yes, the answer is yes. I would expect to deal with you, that you will deal with the case as you will deal with it normally. So yes, if you have a ruler, get your ruler on in the exam, or use the gratitude on your microscope, or use a jewelry loop that I tend to use to measure the specimen. But yes, measure, because you can add an extra strength and extra depth to your answer, because now you will be able to tell me when you decide on Breslow and Clark's, if you are in vertical growth phase or radial growth phase, and all of these has got a lot of prognostic implication and decision on the treatment perspective. The other things as well is because you thought about referring the case to MDT, just also think about the cases which has to be double reported in the same department. Obviously, some department somewhere in the world will double head every cancer case, but we don't do that. Normally, we don't do that, okay? But melanoma cases are cases belongs to that category that needs to be double reported because of the huge implication on that diagnosis on the patient life and future, basically, especially if we are in the areas between the dysplastic and the melanoma. So double heading as well comes with the areas of the high-grade dysplasia. So high-grade dysplasia in the esophagus. Also, we double-head it in the UK system. In actual fact, that not individual preferences. These are things that you need to double-head, or otherwise, in the exam, you will be marked as an unsafe pathologist for it, okay? Because you will be working single-handed without asking for help when it's needed. The complex or the hyperplasia with atypia in the gynae pathology is another area which is suggested by the Royal College of Pathologists that these cases also have to be double-headed. But if you are dealing with squamous cell carcinoma in skin, or in the oral cavity, or in the esophagus, or neuroendocrine carcinoma, these are not cases that we tend to double head normally. So providing that you guys know what protocol apply to what, then you will be fine. How you will get collectively those? By reading the data set. So I told you last time and previous times that it is important to highlight the importance of the data set. Has to be read. It's for your macro station, but it will also help you a lot to build a lot of these extra points for the micro. The other things, the other point which I want you to think of is if you are dealing with a complex case, like for example, Ewing sarcoma, or even a case of osteosarcoma. Then if you diagnose an osteosarcoma in the exam or angiosarcoma, in reality, what we will do, that all of these cases, which are highly sophisticated, especially the soft tissue and bone tumor category, that these are the type of cases which we will need to send for a specialist. So that's come under these pediatric cases as well. So if I am to get a new blastoma or Wilms tumor in the exam, by all means, I will be heading to the diagnosis with Wilms tumor if I know if it does fit and every immuno fits and all of that. But you will need to see what is the limitation of your service. You know, pediatric pathology is not a specialty that a general pathologist in the United Kingdom do. Although in your country you might be doing that every day, but we don't do. Therefore, pediatric cases, I will be, for example, referring them to tertiary referral center for confirmation of diagnosis and any additional tests that might be deemed necessary. The same things apply for the soft tissue. So these 8 points, I think there are 8, these 8 points which I have just mentioned to you now, guys, these are the points which you need to put for every single case that you will get in the exam in order to score the 3.5. You need to think of them systematically, as I just said, and then you will find that they will help a lot and you will be absolutely fine and you will live happily ever after. So my sessions, I tend to talk a lot. I apologize. But it is just the stream of thoughts will only come like that. As you can see, I don't prepare and I just take you through the cases. So I hope again that for those who know this upside down, don't get upset from my approach here, because I am teaching you for the exam. I'm not teaching you about pathology. So please, 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 just tolerate me, and hopefully we'll get to the bottom of this, believe me. But the melanocytic lesion is a difficult area, and unless if I stand by the common cases that comes in the exam, it will be very easy to mix them up. And then it, as I said, it will be pretty to lose it, because everyone in the United Kingdom will be getting those like that. Yes, the final diagnosis of this case is compound Spitz nevus. Don't forget, Spitz can be junctional, can be compound, or can be dermal, or can be desmoplastic. So this is the compound one. And of course, we will, if you obviously want to know about the other types, you can read. But the other types doesn't come a lot in the exam, so don't panic, okay? So just let's focus on the exam, and this is what we will do. The Immunohistochemistry Assessment, I will think of immunohistochemistry as additional work. So in the exam, immunohistochemistry comes in as part 3 of your answer. In Spitz, it's not going to function, no. So the answer is that it is a pure morphological approach on the Spitz, and I don't use, and I have not seen pathologists using immunohistochemistry for Spitz. Not reads, because we will talk next time about reads. I promise you. I was planning today, but then we got dragged into what to write for the exam. So this took the time of the reads nevus. But next I will open the next session with the reads nevus, and you will understand the subtle difference between the two when we come to reads nevus. But as I said, a lot of these epithelioid spindled melanocytic lesions, they rely on this. Yes, I will get you a case of a typical spits. Again, just remind me for if you are attending next time, I will make sure that there is a spits ready. I prepared this time few cases in the background, including the reeds, including the dysplastic nevi and the superficial spreading, but I didn't have time, and your time is valuable as well. So the problem is we cannot extend it beyond the hour because a lot of you has got other commitment, and I will lose your focus anyway. So we have to take it step by step. But this case does come in the exam, but you know to some extent how to approach it now. So someone just asked me to summarize. So for those who are just staying, to summarize the main key features of Spets nevus. You need to stay a little bit at the low power. So when you stay in the low power, you will get a lot of sense of this lesion, and it has got a little bit of a wedge shape into it. It is usually quite large nevus, spread throughout. It is very well circumscribed, which means that there is a sharp demarcation where it starts and where it ends. You can see it even at low power. You don't need to go at high power. There is a lot of hyperkeratosis. You can see it in the surface here. There is a uniform elongation of the VT ridges. And in between, you see the papillary derms filled with large nests. These large nests are filled with epithelioid cells that has got a vertical alignment rather than horizontal alignment. There will be some retraction artifacts around this nest. There will be some caminobodies like here, and there will be some occasional pagetoid spread that you tend to see it more toward the center of the lesion. The cells in the dermis tends to look very similar to the cells in the junctional component, which is not usually a phenomena that you tend to get in a lot of melanocytic lesions, especially in lentigo maligna and superficial spreading. But then you tend to have some element of maturation together with more dissecting collagen that you tend to see it more toward the depths of the lesion. But the key is that you don't get deep mitosis, no abnormal mitosis whatsoever anywhere, either in the upper half or the lower half. And also you tend to have a little bit of a more horizontal alignment of the dermal component, especially in the center, that's all ending at one point. And that is the summary of this. So I hope that this was useful, and I shall catch up with you guys next time. And thank you very much for tuning in. Thank you.